Hotbed Talk.
I want to remind everybody in the audience who I'm hopeful had a chance to listen to Glenn's lecture on methadone use in the perioperative space. We're inviting questions on Slido, and we'll be receiving those throughout the course of this session. Evan, I'm going to invite you to introduce yourself first as one of our panelists for this session.
Thanks, Sal. I'm Evan Karish. I'm professor of anesthesiology and vice chair for innovation at Duke University, and I'm also the editor-in-chief of anesthesiology.
Glenn, can you introduce yourself?
Thanks, Saul. My name is Glenn Murphy. I'm a clinical professor of anesthesiology at University of Chicago Pritzker School of Medicine, and I'm director of clinical research at North Shore University Hospital, which is a private practice hospital a little bit north of the city of Chicago.
And Vicki?
Hi, I'm Vicki Morton. I am the Director of Clinical and Quality Outcomes for Providence Anesthesiology Associates in Charlotte, North Carolina. My main role is overseeing our enhanced recovery program in the hospital system that we're at.
Let me try to get us kicked off here. Methadone, my goodness. Methadone? That's a drug older than me, for goodness sakes. Why the resurgence in interest? I know you touched on this, but from a very high-level practical point of view, Glenn, Evan, Vicki, share with us what your thoughts are on why we should reevaluate this old drug for a new application. Glenn, I'm going to let you kick off.
Yeah, it's an interesting question, particularly I think in the era of ERAS. There's been sort of this push to less opioids, sort of shorter acting drugs, quicker recovery. So I think it almost is counterintuitive, I think, to think about the use of methadone in this setting. But I'm going to steal your quote, Evan. Methadone is an opioid-sparing opioid, which I think is a beautiful way of describing what methadone does. It is an opioid, but it has a lot of other unique properties, I think, that just really can benefit patient outcome. I think particularly there's an NMDA blocking properties of the drug, which may play a role in some of these additional benefits I talked about in the lecture. It raises norepinephrine and epinephrine levels in the brain, may have improved sort of patient-perceived quality of recovery after surgery. Again, the primary benefit is this long-lasting effect. You get this nice long peak effect that persists for a long time after surgery. And particularly, we're concerned in the opioid crisis era of really reduced opioid use. And I think data that Evan's shown from some research he's done in his group and some research we've done in our group, that these benefits can persist for long after surgery. That may be an analgesic benefit that persists long after surgery that may result in people using less opioids after surgery.
Vicki, from the prescriber, and obviously you're intimately involved in ERAS management and launching programs, is there a version? Is there an initial sense of paradox that you sense on the street when the idea of prescribing methadone in an enhanced recovery protocol is introduced?
Yes, there's been a lot of discussions about it. It's taken quite some time for the group to come on board with it and think about methadone in a different light. Again, like you said, it's such an old drug and it's not been part of their prescribing habits in the hospital, especially for acute pain management. So people have had to come along. It's taken them some time, but I think we're there. And there is some great literature out there that has been shared with them, some great data, especially in cardiac surgery, which is where we are using it. And I would like to expand it out to other service lines as well. But it makes sense, when you think about opioid plasma concentration and onset of effect for, say, morphine or fentanyl, quick, and it's also quick to leave. So in our case for cardiac surgery, we're seeing, doses of 1,500 mics of fentanyl being given in a case when if we can give some methadone and decrease that and then decrease the post-operative opioid demand, why wouldn't we? So and I had not heard that before, Glenn. It's what did you say, the opioid-sparing opioid?
We got to give credit to Dr. Karish for that pithy statement. An opioid-sparing opioid. Evan, you want to elaborate?
Sure. I think about this in a couple of dimensions. One is, what is it that we want to do in our brief episode of contact patients in the perioperative period? And I think it's providing superior analgesia We know that a large percentage of patients state that their postoperative pain is not adequately treated. We do want to adequately treat their postoperative pain. We want to set them up for as best a recovery trajectory as possible. And then again, that includes providing good analgesia even after they've left our contact, if you will. And it's also diminishing opioid-related side effects. And by using a long-duration drug like methadone, which reduces postoperative opioid requirements, you could, by reducing additional opioid use, you can reduce the risk of opioid-related side effects. So it does provide high-quality analgesia, better than short-duration opioids, better patient satisfaction, and it diminishes postoperative opioid use. Not only in inpatients, but we've also looked at this in outpatients, both in terms of same-day surgery and 23-hour admits, where again, we get better analgesia and we diminish postoperative opioid use for up to 30 days postoperatively. So it confers benefits along the dimensions of better analgesia, better patient satisfaction, decreased postoperative opioid use. So it really has a number of benefits, and we've really not seen any issues. Of course, there is theoretical concern about postoperative respiratory depression, but used in correct doses, this is not anything that has been seen in clinical studies. It's not been seen in our experience. We've not seen any differences in postoperative nausea and vomiting, for example. So it really does confer a number of benefits, but without any greater side effects.
Speak about dose response. That's an area that I think we're becoming more and more comfortable with. Weight-based, not weight-based. What should we do? What do you do?
I'll take that one. It's a really good question, and interestingly, there's not a lot of information. We did a dose response study in kids, and we've done 2 dose response studies in outpatients. The initial studies describing the use of methadone in the perioperative period used 20 milligrams for everybody. And that was for things like anterior cervical fusions, open cholecystectomies back in that era. In that group, about a third of the patients went home needing no more opioid. About a third needed orals, and a third needed some supplemental IV. But there's not been a lot of dose response studies done in inpatients. The data in outpatients suggests that with a fair degree of safety, and conservative dosing, 10 milligrams in the dose response studies seemed to be a good dose for same-day discharge, 15 milligrams for 23-hour overnights, and I use 20 milligrams in inpatients. Question about weight-based dosing is interesting. Anesthesiologists are typically used to doing weight-based dosing. But for the most part, pediatrics aside, the rest of medicine doesn't do weight-based dosing. And the issue with that, particularly in an era when we see so many obese patients, is again, what weight do you use? And the message is really, when we did the studies, we did weight-based dosing, but then we converted that over to a flat dose to obviate the question about which weight to use. So typically in pharmacology, in general, you use ideal body weight, but we've found that we've not needed to do weight-based dosing with methadone. We've just used a flat dose.
So I just wanted to ask a question since we're on dosing. The studies that I've read, they're all IV, intra-op dosing, and there isn't much on oral. So in an age right now where we're all trying to save money, we're not allowed to use IV methadone. So we're forced to use oral. I have read that there's a conversion factor of about 1 to 2. So if you're talking 20 milligrams of IV, 40 PO, bioavailability is, kind of wide. What do you both have to say about that? And is that the right way to think about it when you're talking about, say, cardiac surgery? Is 40 milligrams oral prior to surgery adequate? Is it too much? How do clinicians figure that out as to what the right dose is?
Can I add to that question and ask Glenn and Evan to speak about whether or not liver or renal dysfunction contributes to that answer?
Sure. two parts to the answer. I have no experience using oral methadone in the perioperative period. We know from a number of studies that the peak oral absorption occurs at about 4 hours after the drug is administered. Bioavailability is about 85%. And there is some variability in oral bioavailability. The drug does undergo first-pass metabolism. We know that there's much more variability in systemic methadone concentrations with oral administration because of the first pass effect. And then obviously the biggest issue is onset. Peak onset with IV methadone is not that dissimilar than fentanyl, for example. In other words, pretty quick. With oral, it is sustained, or it is delayed rather. And my experience in healthy volunteers is that there may be a little bit more nausea and vomiting from oral methadone than there is from intravenous methadone. And at least in our institution, the use of intravenous methadone is pretty standard, and our institution does not find cost to be a disadvantage. So there may be some ways to explore this to mitigate some of the cost factors. But the time for absorption, the variability, and the fact that we just don't see patients 4 hours before surgery, for us means that intravenous administration really is optimal.
I think it's interesting. The cost of intravenous methadone has gone up significantly recently. It used to be a much cheaper drug, and I'm not sure what that's related to. It's probably, I'm guessing, more and more people using the drug. That may be a factor in it. But I agree with everything that Evan said. As I mentioned in my talk, that's a big question. We don't know what optimal doses are. I think the work that Dr. Karish's group has done is very interesting, using a dose of average of 9 milligrams, not only to get very profound analgesia while the patient was hospitalized for 30 days afterwards. So it's possible we may not need these much larger doses in our patient. It reminds me of when we started doing intrathecal opioids and we give a dose of intrathecal morphine of 0.5. We found that a dose of 0.1 was just as effective and safer. So, I think that's an area of, potential good research in the future. What are sort of these optimal doses that we can use? Maybe we don't be, the 20 milligrams comes from Gorley's initial research back in the early 1980s. And that sort of continued. Like I said, the only dose response study that's been done was Dr. Karish's group's done that. So I think it's an area I think we need a little more research in.
Vicki, when you use this in the cardiac surgery setting, I'm always interested in the non-anesthetic properties of an anesthetic or the non-analgesic properties of an analgesic, particularly when we're so in tune to titrating to other things. Have any of you confronted the problem of not being able to take it back when you're using such a long-acting agent?
Yeah, there have been several conversations about that as well. And the first couple of times it's almost done in a little bit of anticipation of potentially a negative side effect, and we can't go back and do anything about it. But it's worked out thus far, and we're very early, so I can't really even speak to our outcomes with it yet. But certainly we're going to be watching very closely and every single patient to see if we have to adjust.
In our study in cardiac surgical patients, again, we closely monitor those patients for, again, obviously a big concern is respiratory depression, which we did not see when we gave dose. We gave a dose of 0.3 milligrams per kilogram in that patient population. I think the concern is if you do develop respiratory depression, you probably need to start an naloxone infusion. So it's not as simple as in the recovery room where we give someone a dose of it and they do better and we don't have to worry about it. If you do see respiratory depression, you're probably going to need to start a naloxone infusion and watch the people very carefully. So if there's an adverse event, it requires close monitoring for a much longer period of time, but we haven't seen that problem in our institution. The only time we had a problem with respiratory depression using these drugs, when we did a study where we designed a study so 2/3 of the dose of methadone was given at the start of the operation and 1/3 was given at the end of the operation. And the only reason we did that was to try to sort of standardize the study design. And we did see some respiratory depression. We had a couple patients who had respiratory depression when we attempted to give a dose right at the end of the operation, which I'd strongly recommend not doing. I think it really need to give the dose at the beginning of surgery. The second time, I think, where people get into problems with respiratory depression is when they use other opioids, bigger doses. We typically use like 100 mics of fentanyl at the start and don't give anything else. In some circumstances, clinicians have given, for example, 2 milligrams of hydromorphone at the end of the case. That's when we've had the problems with respiratory depression. But I think when we've dosed it appropriately, we haven't seen that problem. And that we've seen that particularly in our cardiac patient population.
Evan, what about
Yeah,
vasodilation?
not a concern that I've encountered. You sort of amplify the previous comments, and I don't want to incur the wrath of Mother Nature or bad luck, but this is a problem that I've not encountered in terms of postoperative respiratory depression. The doses that we use are conservative, and as long as a case goes longer than 45 minutes, those initial boluses redistribute. Blood concentrations drop below the threshold for respiratory depression. I encourage practitioners to get patients breathing spontaneously at the end of the case as early as possible, and using respiratory rate as a guide for the need for any additional opioid. We also use, in patients who've gotten methadone intraoperatively, we use it postoperatively as well for the same reasons that we use it intraoperatively. But again, it's very conservative dosing, and we build careful guidelines around the use to make sure that respiratory depression doesn't occur. But I concur completely with Dr. Murphy that if you do encounter respiratory depression, you're more or less committed to a naloxone infusion for a period of time. The one other risk space, if you will, in addition to stacking opioids, if you will, is the concomitant use of sedative hypnotics with opioids. And this is true of all opioids, but it's a particular risk space with long-duration opioids. So, for example, administering drugs like gabapentinoids, sedating antiemetics, dexmedetomidine, other CNS depressants in combination with opioids will potentiate opioid-induced respiratory depression. So I encourage people to not use those drugs in combination. And again, it's particularly important with long-duration opioids.
Dr. Karish, I was wondering if I could ask you a question. It's a question I get asked often by my colleagues. It's about the safety of methadone in the morbidly obese patient. I've seen just one study that looked at the use in bariatric patients that didn't show that that was a problem. But that seems to be the primary concern amongst my colleagues when we use this drug is, well, the patient's morbidly obese and has sleep apnea. I don't feel comfortable giving methadone to that particular patient. Have you encountered in that patient population any problems?
Great question, Glenn. No, I haven't. And you're really addressing two issues. One is morbid obesity. The other is sleep apnea. And we all know that there are morbidly obese patients who have sleep apnea, and there are those that don't. We also know that we encounter patients who are normal body habitus who have sleep apnea. And of course, we also know that the majority of patients with sleep apnea are undiagnosed. So we are routinely giving opioids to patients with sleep apnea. We just don't know that they have sleep apnea. But the important message is that although there's been a lot written about concerns and greater sensitivity of patients with sleep apnea to the respiratory depressant effect of opioids, all the studies that have objectively looked at this to date have not found that they're more sensitive to the effects of opioids. So I don't change my practice in patients who have sleep apnea and the use of methadone. In fact, in some ways, along the paradigm of an opioid-sparing opioid, you could even say that methadone might be more advantageous in this population because they're going to get less postoperative opioid.
I understand that we have a number of people on the Slido who want to get involved in this discussion. This is a question from Sunil Dasari. Methadone, how long do you use it after surgery and at what dose?
We've traditionally just used the dose at the start of the surgery and haven't given anything after. As I allude to in some of the studies, there is data showing the efficacy is improved if you continue the use of methadone in the PACU afterwards. Get the patients, once you get patients comfortable there with additional methadone, they seem to do very well postoperatively. But we haven't instituted that practice yet at our institution. I know, Evan, you remark that you have.
Yeah, we use it in the recovery room in patients who have gotten methadone. I'm not aware of surgeons who are using it either at home or on the wards, and I would not be encouraging of that practice, frankly. You really do need to have a pretty good understanding of the pharmacology of this drug, and I'm not, and I don't know if there is that level of understanding. The other is that once patients are leaving the PACU, more or less they're tending to be treated with oral opioids. And again, there's no data that I'm aware of that have thoroughly evaluated the use of oral methadone in the post-PACU period.
We do not have it part of our pathway at all in the postoperative period. We don't use it.
So if I could just add to that question, are there any circumstances whereby you would be inclined to use it post-operatively? And what would those circumstances be? And if you were to dose it, I guess, how would you dose it, to go further on that question?
Yeah, the way that we do it is, and we've written some standing orders for this, is 2 milligrams every 10 minutes up to 6 milligrams. And after that, we want a phone call. And the reason for this is, again, based on the data originally from the Gourlay studies that showed that in patients who needed additional intravenous opioid in the postoperative period, generally a 5 milligram dose was very effective. I take a more conservative approach. I suggested used 2 milligrams at a time. And after a dose of 10, 15, or 20 at the beginning of surgery, depending upon the case, and then up to 6 in the recovery room, it's very, very rare that patients need additional opioid. And if they're still in pain, I simply want to get a phone call so that I can come by and evaluate the patients myself. If they are truly having more surgical pain, then I'm comfortable, but I don't want to write standing orders for this. So again, our standing orders are 2 milligrams at a time, every 5 to 10 minutes, up to 6.
If you started the case with a methadone load and there was breakthrough, would you advocate switching to a different type of opioid?
I would not. Opioids all work on a dose-response basis. There are not populations who, quote, don't respond to one opioid but respond to another. These are generally a dose-response phenomenon. What I do is I said at the end of a case, I'll get a patient breathing spontaneously while they're intubated, while they're asleep. If they're breathing 20 to 25 times a minute, I'll give them additional 1 or 2 or however many milligrams of methadone to get their respiratory rate down to 12, 15, because I know that if they're breathing 25 times a minute, they're going to wake up uncomfortable. If they're breathing 12 times a minute, they'll generally wake up very comfortably. But I, again, titrate it to respiratory rate, and I use respiratory rate as that guide while they're asleep.
Our next question from Anonymous. Have you got much experience using methadone perioperatively in chronic pain patients who may or may not already be on opioids?
I think a lot of places where they initially start using methadone is in the patients undergoing complex spine surgery. And a very high percentage of those patients are chronic pain patients. And that's why I think you see a real benefit for this drug in this patient population. It started in our practice where our pain doctors were using IV methadone in these patients in the recovery room when they couldn't seem to control pain with other ways. And sort of that had evolved into us using it in the operating room. In most practices, I think I hear methadone most commonly used are in these spine patients, particularly these patients with chronic pain. And there's actually been a study which looked specifically at patients undergoing spine surgery who had chronic pain, who were on large doses of preoperative opioids, and they showed a significant clinical benefit of using methadone. So there is data out there.
Vicki?
So we actually consulted our pain doctors on that exact question and came up with a very similar answer. If we have a patient who is on methadone, we're not going to change. We're not going to do much at all. Just follow the pathway unless there's some sort of a contraindication, but if they're already on it. So yeah, they felt like just continue the practice as normal if the patient's on methadone.
Methadone is a little bit of a unique opioid in the sense that patients who are on chronic opioids because of tolerance and cross-tolerance will generally have greater opioid requirements. Methadone is a little bit different in that patients who are tolerant to opioids are not tolerant to methadone. There's incomplete cross-tolerance with methadone. So patients who are on chronic opioids have essentially their typical daily opioid requirement. Then they have an additional requirement due to the pain of surgery. But we stick with the same dose of 10, 15, or 20 milligrams because their methadone requirement is not greater because they are on other opioids. And that's something which makes it, again, both unique and highly valuable because you don't have to try and guess what the methadone dose would be in that population. It's the same dose that you would need if they were not on chronic opioids. keeping in mind, of course, that they still need their daily dose of regular opioid.
So I read a study about the use of an additional NMDA antagonist, a receptor antagonist. I think they used ketamine in the OR, and the combination effect with methadone and the ketamine had an additional benefit. Is that something that you guys do at all, or do you advocate that, not advocate?
I know the study you're referring to, they used, it was a more complicated study. They used it postoperatively, ketamine, methadone, in a PCA requirement, but they showed a synergistic analgesic benefit to that particular combination. There's also an animal model, of neuropathic pain model, where they showed a synergistic analgesic benefit between methadone and ketamine. We're actually, this study we've actually submitted for publication. Both groups got methadone, but one group got a ketamine infusion for 2 days, and the other group got a saline infusion for 2 days. And there was a significant analgesic benefit to the combination of ketamine and methadone. Now, whether you're giving just 20 milligrams in the operating room, there's benefit to that, I'm not sure. But running a ketamine infusion in addition to methadone, actually there's a significant analgesic benefit to that combination. Can
we see the Slido screen up again? How do you monitor for postoperative respiratory depression? That's I'll say a really good question. Do we change our requirements for higher fidelity monitoring, for length of time of monitoring as we advance patients down the recovery profile? What do you do practically, and what do the data say we should do? Glenn, we'll start with you.
Our first couple of clinical trials when we did methadone, we had everyone in at least an advanced monitoring setting with continuous pulse oximetry for 24 hours, because we were new to using the drug. These are patients getting larger doses. And after a couple of clinical studies, we saw no evidence of respiratory depression. So we don't specifically have any requirements for advanced respiratory monitoring. Again, if you think about methadone, the way we're giving a dose in the operating room. If they're not exhibiting any respiratory depression at the time they're extubated, there shouldn't be that sort of persistent respiratory depressant effect. So in our clinical practice, if someone's doing fine in recovery room and comfortable and they're breathing fine, we don't see any requirement for any sort of advanced type of respiratory monitoring.
Vicki, to the cardiac environment that you use it in, are there any notable differences in time to extubation or your accelerated pathways?
So not yet. Again, we're early, so we don't have enough data to really look and analyze it. I can just tell you anecdotally, no, but I know that everybody's on high alert with it. Although they've read the literature, they know that respiratory depression has not been an issue, but for some reason people are still a little concerned. So I don't know, and that's one thing that we are paying attention to and collecting the data on, because we definitely want to improve our extubation times, and I do fear that this is actually going to lengthen it a little bit for the initial phase of this pathway implementation.
Evan, speak to that in the context of convincing hospital policy to be tolerant of the data.
As somebody who's in the business of publishing trusted evidence, and a wholesale believer in the concept of evidence-based medicine, I would say that all of the evidence to date suggests postoperative respiratory depression has not occurred with a higher frequency with methadone than other postoperative opioids. We know that in general, postoperative opioid respiratory depression does occur. Serious respiratory depression occurs about 1 in 100,000 cases, and that's just across the board. But again, patients postoperatively are getting opioids. We know that the first 24 hours in the postoperative period is the highest frequency of opioid-related adverse events. But again, if somebody is comfortable on the dose of methadone that they've gotten in the OR and PACU when they go to the floor, if they don't get additional opioid, then they can't suffer opioid-related respiratory depression. So let me add another point to what we talked about a little bit earlier in terms of benefits. We haven't talked about cost effectiveness. And it is true that intravenous methadone's gotten a little bit more expensive lately, but I've done a lot of big spines where we tend to use total intravenous anesthesia. Typically, that was done with remifentanil and propofol, but a remifentanil infusion, depending upon the infusion rate, will cost you $40 to $80 an hour. If you're doing a 6 to 8 hour case, your remifentanil bill can be $500 to $800, whereas a single dose of methadone, and you can do total intravenous anesthesia with methadone and propofol, you've now dropped your anesthetic cost well below $100. So not only is there some benefits on the effectiveness side, there's also benefits on the cost effectiveness or economics as well.
Can a single intraoperative dose of methadone be combined with a non-methadone PCA post-op? Start with Evan this time. We'll go through that.
Yeah, yes, and it is and has been. I don't suggest or ask our surgeons to do anything different in terms of their postoperative analgesic regimen in patients who've gotten methadone compared to other patients. And often I'll ask patients what they write for, and some will write for oral drugs, some will write for PCA, some will write for on-demand intravenous opioids, nurse administered. But the answer is yes, all of those things can be done effectively and safely in patients who've gotten methadone intraoperatively.
We actually don't use PCAs postoperatively unless we've exhausted everything else, and that's what we're left with. But I mean, maybe 2% of the time are we seeing PCAs on the floor postoperatively. However, kind of the same thing. If the patient did need it, we wouldn't omit it if just because they got methadone, they had methadone.
But pretty much the same thing. For example, in our complex spine patients, we still use PCA hydromorphone, and there's no change. We don't do any change in our clinical practice because of it. So we don't see any issue.
Can methadone be used for postoperative pain and scoliosis corrective surgery in teenage patients?
Full disclosure, I've not anesthetized a child since Jimmy Carter was president. When I was in St. Louis, I did collaborate with our pediatric anesthesiologist in doing some methadone studies. And the pediatric scoliosis population was a target population where we did use methadone intraoperatively. Initially, a lot of those patients went to the pediatric ICU, and some of them were getting methadone intravenously post-op. But my understanding is that now many of those are going directly to the floor and there's less being used. So I can tell you what my awareness is from my colleagues, but I can't share with you any firsthand experience.
It seems like a great drug, and we haven't talked about any reasons not to think otherwise. What's the risk? What should we be concerned about? And in lieu of that, let's talk a little bit about the QT syndrome issue that sort of is a halo effect around this drug as well. I'm going to start with Evan here.
QT prolongation does occur with methadone, as it does with a great many other drugs. But if we look at the dose at which this occurs, in the FDA database that has looked at Torsade and QT prolongation, we learn a couple of things. One is that the incidence is dependent upon the duration of use. So the longer it's used in terms of weeks or months, the higher the incidence, and the higher the dose, the greater the incidence. And the median dose at which QT prolongation occurred was about 350 milligrams. When we talk, and when used for a matter of weeks and months. So in our use in the perioperative period in the range of 5 to 20 milligrams in a single dose, I think that QT prolongation is not a material concern, and we really don't attend to it or pay any attention to it.
Putting QT aside, what are circumstances when you would not want to use methadone? What would you perceive to be a reason to choose an alternative when you have an opioid need?
So we have our cutoff to be for creatinine greater than 2, and of course liver involvement. If their LFTs are double what they should be, we do not give the methadone at that point in time.
Glenn?
And that was just based on some studies.
We have some data that Evan's done on ambulatory surgery patients. I think maybe more dose data related to what's the safe dose in those patients who are having procedures associated with sort of moderate but not severe type of pain. And again, the question that keeps coming up to me from colleagues more than anything else is the concerns about respiratory depression. It'd be great to see a study using very sensitive respiratory monitoring the risk of respiratory depression in methadone patients compared to patients receiving conventional opioids. I think that would alleviate a lot of anxiety people have about using this particular drug.
On a practical basis, are you finding it, the list of reasons not to use it, to become smaller and smaller in your practice?
Yeah. Oh, I totally get where you're coming from. Like I said, our usage typically starts off in these patients with chronic pain undergoing major surgery. After a while, people get comfortable, and it's like anything else, it starts expanding to other patient populations. We've seen it started for years. That was the only group of patients we used it in. But now we're starting to see it expand to some other people undergoing painful surgery, and now into some of these ambulatory surgical procedures. So it's a process, I think, of expanding out. And I really don't see at this point any contraindication to anybody really to receive it.
Evan, I'm going to let you have the closing remark. And with that said, I'm going to thank this panel for really introducing an old drug back to a new way of thinking and practice. Evan, you can close it out.
Thank you. I just enjoyed these sessions because I learned so much from the other presenters. And it's interesting to see how everybody brings their research experience as well as their practical experience to the question. And it sounds as though there's a substantial amount of commonality between the three of us in terms of how we view the challenges of providing optimal and safe analgesia and anesthesia to patients. And we're all looking at this in a very similar way. And that is, this is approach which is inherently non-traditional, but tradition has not gotten us to a point where we think we're providing the optimal care. And this is an approach that provides analgesia which matches the duration of pain, which is our goal, and without an increase in side effects, and in a way that increases patient satisfaction.
Thank you. On behalf of EBPOM USA, Glenn Murphy, Evan Koresh, and Vicki Morton, thank you. Great panel discussion, great information, and thank you all.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.